So I'm just going to start with some pictures here real quick. If you can use this camera right now to just show what we're really dealing with here, right? So if you look at again, we talked about the apex of the rib and coming off that costovertebral joint, and obviously lung is over here.
Looks like a soup ladle.
And that's dorsal, right? That your rib morphology is going to limit your trajectory, right? So if we're talking about coming more lateral, let's say we want to come, a little bit more shallow, like we're talking about in the lumbar spine, we're going to end up doing this, which we don't want to do, right? So your maximal area is going to be somewhere where that rib apex is, right? So you can start a little bit more medial, but you're going to have to know what you're going to be dealing against, because that's going to be the facet, and you're not going to be able to sneak under it. Sometimes, because they're skinny and because their rib of the apex is a little bit more medial, you probably have to do a little bit more facet drilling, so you have to be ready for that. And we talked about missing shallow, right? These are all the good misses, right? You never want to be here and go deep before you're close to the spine. So what we have set up here is already spinal needle again. That's the only thing that's there. That's always going to stay stable. That's not going to move anywhere. I don't know if you're looking at the x-rays now, but it'll be nice to see this x-ray that we're looking at now. So that's how we targeted this space, right? So that's what, like 10, 11 probably. And you want to get a nice end plate view of that lower vertebral body, the superior end plate of the inferior vertebral body. So that's a nice place to start on the AP. And then if we go to picture 2 there, on that lateral, that's something I want to see, right? So number 1, we're seeing 2 needles, right? You just have to know that your first needle there is just marking that pedicle on the contralateral side. That's that disc space we're entering. You can imagine if that needle wasn't there, I'm counting again. I got to figure out if that's the right level. But now I know that I'm at the right level, right? You can't stress enough, especially in the thoracic spine, just get the right level, right? Half your job is done. So now you can see nicely that SAP of that inferior level there, and that needle is right on that SAP. I like to start there, especially for thoracics. I don't need to dock into the foramen or anything, because I know I'm going to drill, and this is what I'm going to do. If you ream, you have to be a lot more precise, right? This changes a lot on how you approach this foramen and this disc. If I don't ream, I could just dilate. I can put this cannula in here. I can find that SAP and start drilling. But your reaming has to be in a very specific trajectory, and you have to make sure that's going in the right place, which is not wrong, but I think it takes a little bit more time, at least for me, right? So everyone's workflow is a little different. So what I would do now is I dilate over this, and then you can see that next picture here. These are just all the dilators on the same spot. Now it's blocking that SAP, but you're going to be looking at that, right? Because this is beveled, and you're going to be looking a little bit more medial. So that picture 4, you can see it's an AP picture of that. So right after I get my dilators and I put my tube in, I get some final pictures before I put my scope in, because again, I want to know where I'm at, and if I hit bone as soon as I put that scope in, I want to be able to predictably say what bone that is, And then once you find that bone, you can work off of that. Whether it's the SAP, the IAP, if you're dorsal, if you're ventral, if it's the pedicle, you know what direction to go after you identify what bone that is. So we already have our working channel in here. So if we go to the endoscopic video, actually you can come out with the C-arm, please. So if we go to the scope view, put this in. You have the bipolar, please. And the first thing you do is make sure that you're looking horizontal, right? You don't want to do this. You don't want to turn your scope. You want to make sure that you're horizontal. So your starting is always the same. So 12 o'clock is always going to be medial for you. So once you clear this stuff out, you can take a pituitary, you can take a bipolar. You can see we cheated because of time. There's a little bit drilling there already.
Sanjay, I think you got some fat on your endoscope.
We'll clean that off here. Maybe we increase the irrigation just for the demonstration. Okay. May I have the bipolar, please? So what we identified, you can see again, dinosaur bone looking stuff, right? That's some cancellous bone. And then you can see a space there, and you can see another piece of bone here. So what are we looking at there? That's the facet, right? So we docked right here. We drilled on this SAP, and then all of a sudden, we're seeing
Hey, Sanjay, is there any, sorry, I mean, we love watching your hands and you, but is there any way that you can clean the scope a little bit? It's very, very grainy and very sort of poor image quality right now. What does it look like for you in there?
Yeah, it's kind of hazy.
Yeah, why don't we maybe
change the scope, maybe?
Or give it a little rub.
That make it any better?
No.
Barely?
Fat on top.
Maybe we try to clean that.
It's a little foggy, I think.
So it's the same steps, right? You want to identify the joint. And what we're looking at is IAP, joint space, and SAP.
Do you do these cases on Open Jackson, or what table do you use for these cases?
Wilson. Yeah. That's because I use the Wilson for all my endoscopic. Someone said, don't change the workflow. That's really the reason I use that, too. The nuance there with Wilson frames is you have to flip it because the gears and stuff will get in the way when you're dealing higher up on that Wilson frame in your X-ray. So just a note, if you're like T9 or higher, you have to put that Wilson frame the other way so the gears aren't in the way of your AP.
Sanjay, do you use navigation typically, or no?
I don't. These are all fluoroscopic imaging. I think navigation's super helpful, especially with targeting. Can you move this tower a little closer, please? Move the tower a little closer, just so I have. Yeah. So hopefully it's a little bit better. Let's see. I mean, you can sort of make it out, but I can see it's still sort of a little hazier. Do you guys agree?
Agreed. Mm-hmm.
So there's the IAP, there's the space, and then there's the SAP. I mean, it's good enough to see this. May I have the drill, please? Working on their scope, or? Okay. We're going to flush this out here pretty soon, but you can see the space. Bone, space, bone, okay? So 3 o'clock is head, 9 o'clock is towards the feet, 12 o'clock is medial, and we're just going to drill through this facet here, mainly through the SAP. Oh, we have Hofstadter walking in. Apparently this image is not up to his standards. Maybe we connect to a different tower, dare I say. So I'm just drilling through this SAP. This is SAP, right? That's joint, that's IAP, okay? So if this was a bigger disc and I anticipated doing a lot more work, I'd take a little bit more of this IAP off, no problem, right? And remember, angled scopes, straight instruments. So in order for this drill to reach it, I need to bring that thing that I want to drill in the middle of my screen. So this is the maneuver I use, just like painting around it. I think this diamond bit works more of like a side cutter. You don't want to push too hard on the cortical bone. You want to use your exposed cancellous, and it sort of just melts away. So just keep painting. And for endoscopic cases, you have to be comfortable, right? These aren't ideally leveled. The tables aren't ideally leveled. You want to be comfortable. You always want your shoulders relaxed, probably at waist level. So in these cases that take up to 3.5, 4 hours, you just don't want to be doing this the whole time. So that's what we're feeling now a little bit. But again, SAP, keep drilling through this. And then now and then you can take some confirmatory pictures, right? These are this is SAP. And then if you really want to see where we are, we can stick a curved instrument in there, ventral to the SAP, and just like we would for the lumbar spine, but I typically don't do that because the spinal cord's there, so I just want to find that space.
Sanjay, can you point out the pedicle to us? Maybe that would also help us.
Yeah. We have the bipolar, please? Oh, grab it. So if you follow this SAP, always find the pedicle. Clean out this junk. You can see that I'm leveraging the tubular retractor and the scope. If I see some stuff here, push it in, push it over, and then move it away from me. So this is going to be ventral to the SAP, and right there is going to be the pedicle behind this junk. So that's the pedicle. Right there. See that?
Very nice.
Goes up to this SAP, then again joint space, then IAP. So again, behind this bone is going to be canal. And I wouldn't do this in a real case, but you can see that this is all space, ventral to the SAP. This is actually going pretty medial there, and this is probably curving medial to the pedicle, but you don't do that because there's spinal cord there. Can I have a drill, please? Okay, yeah. If you have that set up, we can just switch over. Okay, yeah. So you can sort of make out that this is probably the top of the SAP already. And we can work on the top and then bring it down. Just like this, right? So it looks like we have another scope, so let's just switch out just to see. You can see it's a space. We made it into a space, right? So it's the same stepwise process. You find the joint. Based on your pathology, if you want to go more medial, you drill more of that IAP off, and then outside in always, right? You never want to drill some of this SAP, find the cord, and then back out your stuff, and then do more work. Sometimes you may have to do that, but minimizing that as much as possible is going to be the safest route. And then the safest maneuver after you're into the epidural space is drill into the bone, right? If you drill into the bone, you can find the bone, the end plate, the disc, and the end plate interface. And then once you find that, you follow the river of that disc into your spinal cord herniation, or the disc herniation ventral to the spinal cord.
Sanjay, another question. When you say that drill into the bone, you're talking about drilling into the vertebral body to create a cavity to deliver the disc fragment.
Yeah.
Can you talk about, do you have any particular rules or feelings besides creating enough space to get the disc? Do you have a feeling about how much you want to drill out, or is it just really disc dependent?
The medial reach is always the most difficult. So in an angled scope, the way to get more medial is drill deeper, right? So you're drilling more into that bone if you want to reach more medial. So that's going to help you disconnect the most medial portion of that attached area of that disc in irrigation. Did that answer that question?
Yes.
Okay. And the quickest way to get into that and the safest way to get into that is lateral. You're going to see disc space before even seeing epidural space if you wanted to. That's a tad better, isn't it? Yeah, it's right in the middle. It should be focused. That's off, right? Yeah. Did that help better?
It's much better.
Okay, good. May I have the drill, please? Thanks. So yeah, so we're just coring out that SAP. And again, you're not gonna, if I have this at the top of the screen, my drill's never gonna reach that, right? I wanna move all my instruments to get that right in the middle, and then I can maneuver around it. So let's act like we need to get a fairly large disc out, and then, so let's drill more of this IAP. Is there a leak in this? Looks like we're getting bubbles and stuff.
We switched over.
Okay, because we switched. Okay. So IAP, or sorry, SAP, just keep drilling this.
So Sanjay, while you're drilling, we had a question before
Yeah.
that you might have missed. They asked you,
Could you clean this, please?
typically, how long do one of these cases? I mean, you've done a lot of these cases, but
clean
when
that.
you were starting out, how long were they taking you? And you know,
Clean it.
how long did
It's
they
like
take
a
you
bunch
now?
of junk on it. Yeah, I mean, it varies on the type of case. Extraforaminal is the easiest for me, or foraminal is the easiest because you don't have to get into that epidural space. You don't have to see spinal cord. So that'll probably take like 45 minutes, right? That's basically the trajectory, putting your scope down, finding the loose fragment, and taking it out. That calcified giant disc that we saw in the presentation, that probably was a little under like 4 hours. So, I mean, I would say for an endoscopic case, it's long, but if you consider the alternative, I think it's still pretty good. But yeah, it certainly takes longer. And it really depends on what your goal is. I would say, a good amount of that time was trying to peel off that last calcified rim. So it really depends on what the goal is. And maybe it would have went faster if I broke it up into many pieces, but it's certainly a consideration. So now you're starting to see see the curve here, right? The curve that we're all used to. That's not going to change just because we're in the thoracic spine. So that'll lead you here, right? So may I have the bipolar, please? Could you come in for an AP shot here?
Yeah, I think that's a good point. You said 4 hours. I think that's because I think the goal is you just want to make sure you do a great job. You don't want to leave anything there. So I think you just take your time. And usually when I book these cases, I don't book them for a short amount of time. I just, if I finish earlier, I finish earlier.
Yeah, and you always want to, you feel like you always need to go fast for this, but again, you always have to consider the alternative. What are you really avoiding by doing this? And you just have to just be okay with it. Take a shot here, please. Okay. Is that a new shot?
Need the shot with the RF probe in there? Yeah.
Yep. Okay. So this is sort of what we expected, right? You can see that this is the IAP. We've drilled a lot of it off, or sorry, the SAP. We've drilled a lot of it off. Curves down here into the pedicle. It's probably the top of the pedicle. And then if I could drill more of this off to get a little bit more inferior if I'd like, but I could follow this down to the disc space. And this is probably the disc space lateral to our level, right? Take a shot here. So that's right on disc space, right? So I could get into disc right now to add a little bit more to that answer for Mark Mahan's question. You can get into the disc now. You can find this superior portion as inferior body. You can find the inferior portion of that superior body. You can find the actual disc space and follow that ventral to the cord. And that's where that's going to be. But just so we can see how that looks, we can move all this stuff, and then we can get a little bit more visualization here. May I have the drill, please? So you can see that my tubular retractor isn't in this hole. If it was in this hole, I'd have very little maneuverability. My scope is hugged in the web of my first and second digit, and I'm able to extend my middle finger up and down to really move that everywhere. My tubular retractor, again, since it's not in that hole, I could move it all around. I could get whatever I want to drill in the middle of my screen, and I keep drilling. So if I wanted that IAP, I put that IAP in the middle, and then I drill up on it. So this, again, the same sort of painting up and down. And the goal is to get through that SAP, just really like any other trans SAP. But remember, avoid plunging. and leverage your natural barriers, right? There's ligament there. So sit on that ligament and really just clean that out and make a nice little plane there. If you keep the shapes the same, you won't get lost, right? So if I change that arch and just completely got rid of it, then I wouldn't be able to identify it. But I'm keeping that arch, so I know that's sort of in that area. So again, turning my scope. If I turn it up, all of a sudden, what's middle, what's midline, what's north, what's south, I'm not sure. So I always get myself back to orientation by looking medial, so I know 12 o'clock is medial. So if I wanted to open up that space more, I can do that.
So Sanjay, what's your instrument of choice? Once you have a calcified disc and you cord the inside, you have that rim and you want to push it down into your defect. What's the instrument you like to use to push it down?
I like to use that dissector. First, I probably use the bipolar more than any other instrument in every endoscopic case, right? To get in between planes and define planes and free attachments. That thing probably works the best. And then once that plane is created, maybe if I have to, the angled nerve hook will get into that area and bring it closer to me. But once I'm able to put a dissector in there, it's strong, so I'll use that to break off that last piece and sort of pull a fragment into my view.
And I noticed that you're drilling the SAP very dorsally. Is that because you want to be able to see the whole spinal cord? Because sometimes you can see it dorsally and ventrally if you drill the facet a lot. Yeah. So this would be sort of an approach for a larger disc. I want to get more maneuverability once I'm down there. Again, there's a shelf of IAP. I can take a little bit more IAP off, and I could finish off this SAP with the drill. Which we're doing now. And then you just walk lower. And again, the ergonomics of this thing, you want to be comfortable during this thing. You don't want your shoulders up like I have now. You want to have the bed comfortable at a level that you need to be, because your shoulders could get worn out pretty fast here, especially when you're sort of like shrugged up. Okay, so that's one way to find the epidural space, right? We always see the fat sort of coming into us. And I could take some keratogens and pituitaries and remove that soft tissue there. Another way to find the disc space is just look lateral. May I have a pituitary, please? And then find the actual disc, and then take that disc, go into the disc, and then take some of the bone, and then travel medially after that. That's also safe because you're in the disc space. So all this stuff is a little junk over the disc. We know that's disc because there's nothing else that should be there that SAP to pedicle follows, right? Right on top of it is disc. Can I have the bipolar, please? So really, at this point, you're getting some bleeding, right? You got a bipolar over this. And then again, like everyone was saying before, the drill really helps you define planes, because once you find the cancellous portion of your end plates, then you're able to follow that more medial. So usually, obviously in a live patient, this would be a nice white blush of the disc. Maybe able to see. Let me see a drill, please. So what I want to do now, you just continue following this, and again, we're actually pretty lateral to everything. Take a shot, right? So this is not even in the canal, but I want to dive into the disc to show you. So this is a disc space. We can go get into the disc space, and then find bone. Bone above, bone below. Pituitary, please. Can you slide back with the C-arm, please?
And again, I'm just showing you a different way to get to the same place, because obviously you guys see that pulsating thing there, right there. That's the epidural space. But what I want to show you is, so this is into the disc space, okay? And what we want to do is just follow that disc. If we follow this disc, pituitary again, sorry, and then a bipolar. If we follow that disc medial, we'll get to the canal, but ventral to the spinal cord, okay? So you can see that it almost looks like a fusion here, right? So you're seeing the end plates, and you can follow that. Super reliable. So that's bone, right? You see this bone here? This is bone up top, and then probably we can find the superior end plate, or the superior end plate of the inferior body, pituitary. And again, this is, in a live patient, that's all white, right? It's all the disc. Drill, please. So there's the inferior portion of the superior vertebral body, and here is going to be the superior end plate of the inferior body. And in between is all disc. So you again, verify. So let's take a picture here, please. So I feel bone. Now I got to confirm what bone that is. And if we maybe angle, I'll try to move out of your way too. Yep. And then maybe angle more. Great, and take a picture there. Great, so you can see that confirms that I'm on the inferior end plate of that superior vertebral body, right? It's actually a better picture overall, so let's just stick with that angle. And then feel some bone here, take a shot, right? And that's the superior end plate of the inferior body. So I'm completely at the disc space. You can see that it's sort of small. It's smaller than you would think compared to that x-ray, but here's a top, here's the bottom, here's the top, here's the bottom, here's the top, here's the bottom. And you're just going to keep opening that space up, pituitary, and just follow that disc space ventral to the cord. And then if there's a disc herniation, you would see it here. You know, actually, there's no disc herniation here. That's why it's super free, right? And again, you know, you can turn your scope 90 degrees to your instrument, and then you can start biting. So you open it here, and this is all ventral to the spinal cord.
Sanjay, you think you can kind of show us the lateral margin of the spinal cord, just so that they can kind of know what they're working with?
The lateral
margin of the spinal cord?
Yeah, sure. I haven't even identified it yet. Okay. So we know we're in the epidural space. We know behind that fat and that pseudodura of Nelson, we're going to find the dura. So I can show that to you. Let me see a kerrison, please. So with the kerrison, I'll just remove some of this overhanging stuff. I rarely use a kerrison, but you know, maybe upgoing pituitary or something. But just since this is a cadaver and I want to just take a bigger bite, I'm just going to show you. Right. Remember, all your hands are moving together, right? That's how you get to these areas.
So this is more of in this example, it's almost like a lateral, a paracentral disc, but you know, would you want to see the spinal cord in an actual case before you start taking disc out, or do you just go straight for the disc?
You can go straight for the disc. You don't have to identify your thing. You know, we like to see everything before we take care of pathology. I mean, this is, if we understand it well enough, that's in the disc space, that's ventral to the disc. This is the SAP coming down the pedicle here. And that space right there has to be ventral to the spinal cord.
Sanjay, just take the fat down.
I'll show it to you.
Show us the spinal cord.
I'm working on it, pituitary.
Can't deal with that suspense. Yeah. What is that?
So again, trust the fat, right? I can show you inside the dura as well.
There it is.
Yeah.
There
Starting
it
to
is.
see it, right?
Yeah.
That's what they paid to see. There you go.
All right. So right now I'm limited to how deep I can go. So what I would do if I wanted to see this, I would have drilled a bigger window. Let me see a kerosene, please. So I can advance this, right? This is, you can see what's holding me up, all that stuff up top. So I can choose to drill that, or I can just move away from it and get closer. You see how I just dropped into that hole?
A reamer would be nice for that bond, huh?
Yeah, some would say. Some would say. Straight pituitary, please. So there's a spinal cord for everyone who wants to see. And again, you can see this is, you think we're still lateral, but let me just put this, I'm using this instrument so I don't waste time. Take a shot here, please. You can see how medial we are already, right? We're not just lateral to the spinal cord, we're ventral to it because we're coming in this oblique angle. And then I like to use this backwards so I can open away from the spinal cord. Let's see a ball tip so I can show, or maybe a bipolar. Just so you can see the medial reach. If that's all disc that's pushing centrally on the spinal cord, you'll see that. But thankfully,
use bipolar to kind of, from here it's hard to visualize what you're doing. If you think about bipolar, maybe shrink some of that tissue a little bit.
Yeah, all right. Yes, boss. Is that better? Yeah?
It's beautiful.
Yep. So bone, tissue, ventral, probably some ligamentum flavum, ventral to the SAP up here. 3 o'clock is cranial. This black spot is ventral to the spinal cord. This is disc. This is vertebral body. This is disc space. This is probably some PLL. And I'm going to pass this ventral to the spinal cord. This guy was walking around without any myelopathy because he wasn't having spinal cord compression. Take a shot here, please. See that? So we're all ventral to it. If there's a disc here, we can take it out. Yep.
Quick question. You know, like for also a question to you and the rest of the group here right now. When you have a central disc like that, like let's say you have a central disc here or in the lumbar spine, you go transfemoral. How much of the PLL are you comfortable taking out? I typically take it out to the midline so that everything is gone. But do people spare it? Because you know, Luke Kim always likes to spare it. Who likes to spare the PLL? You don't take anything.
Unless the PLL is part of the disc fragment and the actual, it's all adhered, I won't take it. If it buckles, honestly, I don't find a need to go and remove it. I think, if anything, it just helps keep the plane between the ventral thecal sac and the disc space. But when teaching residents these different procedures, I like to actually point out to them, this is PLL, this is that, and then the whole goal is not to remove anything that we don't need to.
You talking about lumbar spine or thoracic?
Either or.
I don't know if anyone's able to see these pictures now, but this is, I mean, we got lucky with this angle. It's so perfect that you're following ventral to the spinal cord with the pituitary. Under direct visualization, you can really
Let me summarize. You're so good you can't believe it? Is that what you're...
That's why I laughed. I knew someone would run with that comment. May I have a drill, please?
So what Christoph was asking, in the lumbar spine, yeah, spare what you can, but in the thoracic spine, make as much space as you need. So like, if you want to get to the contralateral side, you need to create a scope-shaped cavity ventral to the cord, and you can see the contralateral pedicle if you want.
Anybody else? Any comments on the PLL? What do you guys do?
I would say I agree with Ray. Thoracic spine, just make as much space as you need. No point in preserving anything. Lumbar, probably maybe a little bit more caution. It's just because the dura tends to be a bit more kind of float into the field a little bit more. So the more stuff you leave in between you and your tools, sometimes it can be helpful as long as you're decompressing.
So I think Sanjay did an excellent job showing us the spinal cord and a nice thoracic decompression. So unless anyone has any more questions about... Oh, did you have a question? Okay, go ahead.
Yeah, so it looks like your endoscope is all the way down to the cannula. So if you want to go more contralateral, so it means that you need to push the cannula deeper with the endoscope together, is it right?
You'd think so, but this is a straight pituitary. And because of this angle, I'll show you, we're all ventral to the spinal cord. Can you clean that, please? Just real quick. And then I'll go as far as I can go on a direct visualization, we'll take a picture. All right, so let's say there's something here. I could just easily grab that. Take a picture here, please. Right, and then I could go even further by dropping my hand. Take a picture here, please. Right, so that's kind of, if you want to go more deep, but you have to, again, open this window. That'd be all in your pre-op planning. You don't want to come out here and drill once you have the cord exposed. All this would be done already before you get down there, but it's a nice view. You could actually, if you take more of this off, you'll be dorsal to spinal cord. Remember, when we're coming from a dorsal approach, we're sneaking Kerrisons in that medial portion of that SAP, and it's all dorsal. So if I take that fat off, pituitary, it's going to be partially dorsal to the spinal cord. Yeah, I think, are we done with time, or?
Yeah, I think that unless anyone has any more questions, I know this is one of the hot topics. So yeah, we have one more question in the back.
How do you identify a ventral dural leak?
Pituitary?
So the question was, how do you identify a ventral dural leak, and how do you manage that if you did?
Okay, if there's a ventral epidural or a ventral leak, drill. We've treated, John and I both treated spontaneous, maybe Ray has as well, spontaneous CSF leaks. You want to drill more of this into the disc and into the bone, so you actually get ventral, and you could look back up at the ventral spinal cord. So if this was the case, then we could probably do a little bit more drilling, get a little bit deeper, and then see that ventral, because that's central into that's central and ventral into that spinal canal. So that's in front of the spinal cord right there. So if there's a hole, we would see it right there.
Nice.
What would you use to repair it?
Yeah, so the question was repairing it. What would you do to repair it? Anything?
Yeah, so the way we repaired that was on the entry point, we took fat, we took muscle, like very small, tiny pieces, and then we put Duragen. So we packed fat, packed muscle, packed some Duragen, and then squirted some glue in there. And that was our closure, and we took everything out.
For the glue, did you take all the arrogant out first, or just put the glue in?
Yeah, that's a good question. When we're placing these little things, obviously we turn the irrigation off so they don't fly all over the place. So by the time you're ready for the glue, it's been off for a little bit. I mean, I don't specifically put a suction in there. Obviously, it'll cause more problems than it'll help you. But yeah, so the irrigation is off for a decent amount of time before you're ready for your glue anyway.
Do you use fibrin sealant or another commercial product that's blue that we can't?
No, I use the clear stuff.
Okay.
Yeah. You have an upgoing pituitary? I'm going to keep going till you tell me to stop.
Yeah, I think we're done. Unless any more questions.
I'll keep going anyway.
Okay, I think Thank you, Sanjay. That was amazing. Thank you.
Thank you.
You did not disappoint. Everybody can't wait to do the thoracic disc.